Okay, this is the third video, and we are at complications of pancreatitis. The first one is a pseudocyst. A pseudocyst is a cavity that surrounds the outside of the pancreas, and it's filled with necrotic stuff, with exudates and with enzymes. It presents as abdominal pain, and you may actually be able to palpate an epigastric mass. Additional symptoms could include nausea, vomiting, and anorexia. Serum amylase levels go up. It usually will resolve within a few weeks, but it can change to an abscess. And if that happens, that's a very, very serious situation. It can also produce peritonitis if it breaks, because all that stuff that's encapsulated in that pseudocyst gets dumped into the peritoneal cavity. So, pseudocysts are nothing to mess around with. The pancreatic abscess can develop from either bacterial contamination of a pseudocyst or from contamination of hemorrhagic pancreatic exudate and necrosis. The origin of the bacteria that occurs in a pancreatic abscess is not known. Here you have epigastric pain with a tender, palpable mass. In the pseudocyst, the mass is not as tender as it is when it's a abscess. Temperature goes very high, white blood cell goes high, and this is a fatal situation if the abscess is not drained and treated with antibiotics. Now, there is no data that supports use of prophylactic antibiotics in pancreatitis to prevent pancreatic abscess. No data on that. Another complication would be multiple organ failure. During an acute pancreatitis, you get bacterial endotoxins, you get proteases from the pancreas and other agents that can be released into the systemic circulation. It is not very well understood where the endotoxins in an uninfected patient come from, but the complement system gets activated and you end up with symptoms or situations like adult respiratory distress syndrome, which is a non-cardiogenic pulmonary edema. The lungs fill with exudate, with fluid, and oxygen is extremely difficult to get through this messed up lungs, is what I'll call it for the moment. The organ failures can include kidney failure, requiring dialysis, heart failure, where the whole heart just responds in a hypokinetic way. It just, normal ejection fraction is 60% or above. And in heart failure from the activation of the complement system, the ejection fraction can be into the 30s and the 40s. Disseminated intravascular coagulopathy, I believe you touched on that in the second semester. Again, the immune system, the complement system has been activated and it screws up the coagulation situation. Instead of having homeostasis, you have clots and bleeding. So those would be components of multiple organ failure. The more organs that are affected in multiple organ failure, the higher the rate of mortality. Just for example, in ARDS uncomplicated, well, there is no such thing as uncomplicated ARDS, but 50% of people who develop ARDS will die just from ARDS. So then when you add another failing system and another failing system and another failing system, mortality can be quite high. Other problems that can happen is tetany because of the hypocalcemia. Now, if you've been hanging around me at all, you know that when we give diuretics, I'm always concerned about that patient's potassium level. Because potassium has a pretty narrow window, 3.5 to 5, and Lasix causes hypokalemia, and hypokalemia causes dysrhythmias. It is probably the biggest player, but really it's potassium, calcium, and magnesium. All three of those electrolytes have an impact on the conduction system of the heart. It's just that with calcium you have a little bit more wiggle room. Magnesium is not as likely to be profoundly depleted as potassium is. That's why the biggest deal that we tend to make is over potassium. But certainly, you want to be concerned with calcium and magnesium as well. The hypocalcemia and hypomagnesemia can produce the tetany. In acute pancreatitis, the necrosis of tissues can cause hyperkalemia, and hyperkalemia can cause rhythm disturbances. Mortality. With just your basic edematous pancreatitis, there's a 10% mortality. With the hemorrhagic component, mortality goes up to 20% or more. Recurrences of pancreatitis are common, especially if the etiology is alcohol use. Now, if the etiology is gallstones, then once that's determined, the gallstones will be addressed, and so then that patient wouldn't be subjected to recurrences. Under collaborative care, the objectives for care include relief of pain, prevention or alleviation of shock, reduction of pancreatic secretions. Think about what is it that stimulates pancreatic secretions. Clearly, the person with acute pancreatitis is going to be MPO, because we don't want the intestine or the GI system to be stimulating the pancreas to release more secretions. Fluid and electrolyte balance is really important. IV fluids will be managed. Electrolytes will be managed. Prevention and treatment of infection. And then if there's a precipitating cause, it needs to be removed. For example, John Ashcroft some years ago, he was the Attorney General, Missouri Attorney General, and he developed acute pancreatitis secondary to gallstones. Well, removal of the precipitating cause meant addressing his gallstone issue. And I suspect he had a cholecystectomy. I don't really remember. Aggressive hydration. Patients need plasma volume expanders, IV fluid replacement with appropriate electrolytes, adequate enough to maintain circulating blood volume and urinary output. So it's important that these patients are on I&O and we're monitoring their urinary output. Assess your fluid and electrolyte need. Remember that lots of fluids can be sequestered in the retroperitoneal area or in the peritoneal cavity. When this area gets inflamed, the permeability of membranes is impaired and the pores just kind of open up and they allow for fluid leakage into third spaces. Remember, no oral intake, because we don't want to stimulate the pancreas to secrete more secretions. If the patient is vomiting or they have NG suction, that can also affect fluid and electrolytes. Lactated ringers, normal saline are common fluids in this situation. If the patient has hemorrhagic pancreatitis, blood transfusions may be necessary. Pain management. Pain medication is a priority for these patients also. Narcotics, Demerol or morphine IV. Now, there used to be the thought that morphine caused sphincter contraction, but I don't think that current evidence is bearing that out. So, those kinds of things have to be managed case by case. Your book says Demerol or morphine can be used. Some references will say morphine is preferred because Demerol has toxic metabolites. I do know that morphine can produce urinary retention, and so, for a general surgical patient who can't void and has bladder distension, if they're getting IV morphine for pain, that may be an indication to switch to Demerol. Now, I did say a general surgical patient. That wasn't specific to pancreatitis. Antispasmodics like anticholinergics. We should avoid atropine-like meds in patients who have paralytic ileus because those can further slow down the intestinal tract. Manage your electrolytes. Calcium and magnesium is needed. Remember that frequent vomiting or gastric suction can cause losses of sodium and chloride and potassium, but potassium may be elevated if there's tissue destruction. So potassium, you just kind of have to play it according to the electrolytes. We're going to monitor and treat blood sugar. Sometimes pancreatitis is significant enough to aggravate the islands of Langerhans or more likely to impact glucagon. There's also situations in acute pancreatitis where the patient may need TPN. TPN has a high glucose load and may require insulin to support that. So when you see treat blood sugar, that means give insulin. We want to minimize pancreatic stimulation, so we're going to avoid, the patient's going to be NPO. Oral feedings are resumed when the patient is much improved, when the patient's serum amylase levels have gone down and there is no paralytic ileus. If we feed this patient too soon, it'll exacerbate the disorder because it causes the pancreas to release its enzymes to help in digestion, and it can actually inflame the pancreas even more. Now, gastric suction, the patient may get an NG tube if they have severe vomiting, pain, or paralytic ileus. If the pancreatitis is only mild or moderate, an NG tube may be omitted. Nutrition has to be considered, and if that patient is NPO for a prolonged period of time, then TPN may be necessary. We're going to assess vital signs and in particular respiratory status, pay attention to blood pressure, and more importantly, urine output. The whole point of having blood pressure and heart rate is to perfuse your vital organs. And the kidneys are like the windows to the heart or the windows to your body's perfusion. And, in the absence of other disease processes, of course, the patient who's a dialysis patient, this isn't going to count. But in the absence of other disease processes, you could say a lot about a patient who's having a normal urine output. You can also say a fair amount about the interventions, even if the urine output isn't normal. If you are getting minimum urine output, you at least can have some confidence that you are actually perfusing organs. Now, that doesn't mean the patient doesn't have problems. For example, if we're putting 150 mils of fluids like normal saline IV in, the patient's got normal saline running at 150 hour, and urine output is 30 to 50 an hour, their INO's not going to be balanced. That could be a very sick person, but at least I know that I'm getting enough fluid to get those kidneys perfused. Now, I have to be concerned if that patient has heart failure, because if I don't get enough urine coming out, I may have problems with the heart failure because the heart can't deal with the extra volume. But at least I know that I'm getting organ perfusion. I hope that helps. Tachycardia happens when low blood pressure or lack of volume compromises your tissues. Signals get sent out and the heart will beat faster to try to make up the difference. Tachypnea happens if the pancreatitis is producing or beginning to produce respiratory distress syndrome. Here we'd be falling into a serious situation. The hypoxemia, the low blood oxygen levels, can develop rather insidiously, kind of sneaks up on the patient, and out of proportion to the severity of the pancreatitis. So sometimes the pancreatitis itself isn't all that awful, but the complement and immune system has been triggered and the patient develops ARDS, Tachypnea is one of the early signs because the problem that this patient